So the charge today is to talk to you a little bit about what we call high-def imaging or high-definition imaging. And so it's relevant to me because neurosurgery started off by surgeons doing operations, including complicated operations with loops. Now, we then migrated to the operating microscope, and you can imagine this is the kind of detail we see under an operating microscope. You can see multiple cases of aneurysms. There's atherosclerosis, the angulation, the detail, the perforators, the branch points. These are all being visualized because of the microscope. So while it's really that effective in open surgery, why would we not do that in endovascular? And so that was the task that we, my mentor, Dr. Nick Hopkins, actually reached out to his partner, and who was a physicist and X-ray specialist and engineer, Dr. Steve Rudin, to say, hey, can we get X-rays to do better than where we are right now? Could it improve device or anatomic visualization, improving safety of procedures? And so he came up. So this is one of those original prototypes. Here it is mounted to an actual C-arm, where you can see this is the original device that he came up with. So this is a microcatheter, and you can see the coil wind within it of the microcatheter, and these are coils being delivered. And he was able to bring this down to 35 micron resolution, where you could actually see the difference between one pipeline inside another pipeline. So that was the kind of resolution you're getting. And so from that original study that we did in humans, the prototype that we have commercially available gives us about 70 micron resolution pixels, which is now available for clinical commercial use. And that's what I want to share with you, is the value of this system is that there's a smooth transition between the standard flat panel detector down to high def with standard FOVs compared to the new high def zooms. And really it's just a touch of a button as you mag up or down to zoom in from one or the other. So this is an example. This is obviously a phantom, but there you can see two braided devices, and under conventional flat panel versus high def, you can see the kind of detail that you get. So this is a standard flat panel detection of lateral fluoro, and this kind of shows you as we go from 12 to 10 to 8 to 6 inches. And that's the end of flat panel, and this is where we go into a 3-inch and then 2.3 inch. And then this is what's currently available, a 1.5 inch. So you can imagine the kind of detail one can arrive where you are seeing the platinum wires, but you're literally even seeing the chromium cobalt in there. And you can see the compression of the device in here and a little bit more maybe relaxing out here and out here. So it really allows you to visualize the device like never before. So the question then became, well, what happens to the radiation dose? That was the first thing. You must be radiating them. So the point is that when you have the integral patient dose based on the KAP value, it's a lot lower because of the much smaller volume which is being irradiated. And so it really is the best example for this is that it is a high resolution X-ray microscope, just like the one I have in the operating room. And this really can make it quite unique, where you have pixel size compared to a flat panel of 194 down to a 75 micron resolution. That gives you a lot more detail that you would not be able to otherwise garner. And so, and the radiation dose becomes a lot better based on the fact that you're going for a much, much, much smaller area than you would otherwise. So here's some case examples that I like to share with you guys. Here's a 31-year-old with family history of subarachnoid and has a 5 millimeter aneurysm. You can see it's a dissecting aneurysm. She comes in with a new 6-nerve palsy, and there is the standard FOV. You can see these are video clips, not still shots, and this is under high def. So we'll go back and show you this was under standard flat panel detection. And now under high def, you can see that and this is not like a digital zoom. This is truly, even the perforators, the inferolateral trunk complex that you're starting to see is really quite incredible in terms of the detail that you can see. And now you can see that we are up there with the ready to deliver a flow diverter. And this is the flow diverter being deployed. So there you can see it's being pinched. There's the distal capture coil. There's the distal wire. You can see the little connections in here. You can see the central wire going through it. You can see compression, expansion. So this is an actual case where you can see this kind of detail with all those times as the procedure is being done. So this is something that we had never seen before. And then what you can do is you can do cone beam CT to look at opposition, but look at the kind of apposition you get under high def, where you can very nicely see the device is fully opposed in the region proximal. Obviously, it's not in the region of the aneurysm, and it's fully opposed distally as well. So I think that is really quite tremendous. This is, again, standard flat panel detection at the end. Here's another case, 38-year-old, multiple Ica aneurysms. And again, you can see there's an aneurysm farm here. This is standard flat panel detection and has that paratracheotomy. And there, this is, by the way, it's being done awake. The patient actually coughed while we were delivering there. You can see the head opening up. But again, this is the device being delivered and the kind of detail you can see with each angle, with each point. You can see what's happening. Is it flat? There's a wire. And again, you're saying, okay, we need to straighten out the energy. There's too much energy here. Let's release it. And then we'll try to straighten it out. There you can see trying to straighten this window out. And this is always a challenge with flow diverters. But okay, how do we open it up? Now you can see we've opened it, but there's a little bit of a waste here. Okay, that is going to be unacceptable. So there is bringing a larger catheter to see if that opens it up. It's still not good enough. So we need to do something else. So you want to make sure you leave. There you go. Now we just release that tension. So let's look at that again. So we are trying to open it up. There's the flex intermediate catheter. There's the microcatheter. And you're pushing the whole device. You're pushing it forward to really get that energy out there. You can see the proximal end is open, and there it just foreshortened. And that's how you confirm that you have good visualization. Again, same thing here. You are making sure that the visualization is excellent in the regions of the aneurysm, particularly proximal. And then you can see the great stasis that is created by the distal carotid aneurysms. And there's the final result as well. So that's the kind of detail that one can get with standard procedures. Here's a 30-year-old, another presented with the worst headache for life, however, no subarachnoid. So this is somebody we brought to the cath lab, and it's got an interesting, quite robust inferior apophyseal artery with blush in the posterior. You looked at it twice and thrice to say, hey, is there something special going on? But no, this is just a standard paraclinoid aneurysm. Again, this is the Fred that we just saw Dr. Caputo show. But look at how much better you see this. This is the 2.3 inch. So there you can see the device. Every single platinum wire is very, very nicely seen. And it's being delivered. There's a microcatheter that's been jailed. And you can really make sure the device is open. In fact, this is compressed imaging, but if you're seeing it under real fluoro, you're able to actually see the nitinol threads that are here as well, not just the platinum wires, but the nitinol ones are also seen in under X-ray. And again, you're making sure you open it up. We release it, and then we'll make sure that we release the distal tension. And once we have it there you can see it's still angled and it's elongated in the distal part. So that is something that needs to be addressed. So again, you can see this is a coil that's just going outside, visualize very clearly, and therefore you reposition and you continue to coil till the cows come home, till we're really comfortable. And once we have done that, then we can really make sure that we have completely pushed the stent, and there you can see the thread has been pushed up into the proximal horizontal segment, so it no longer is elongated in the vessel wall. Alignment is much better. Now, part of what you still can't see perfectly here are the nitinol rings in terms of apposition. That's where pipeline visualization is a little bit better, but I think that still makes quite a difference. And this is our standard views of the same exact case, and it really shows you how much better you can see under the higher magnification. Here's a 56-year-old, multiple aneurysms, and again, multiple flow diverters. This really becomes really tricky when you're doing these cases, but here you can see very nicely this device. You can see very nicely this is now compressed. You can see very nicely the distal wire, the central wire, the distal capture. You can see detachment zone, and you can really appreciate the device behavior as it's being deployed to make sure that device behavior is optimal. There it's being compressed again to make sure we're good, and then device is released. And this is how we then extend the device to fully cover and compress in regions where you want. And you can see it's not just true for lateral, but AP, both planes are very good. And this is the sort of detail that one can get after deployment of the device. And now an extension is being applied with a second device to cover the more proximal cavernous aneurysm. And there we go. There is release. And you can actually see very nicely where the release is. And then you can see it just jumped up. Want to make sure that we have good wall apposition, but it doesn't necessarily mean. There you can see the compression right there. And so that's now optimally shortened off on both planes to confirm that we are in a good position. And there is, again, with contrast imaging, you can see very nicely wall apposition here, although there's some lack out here. And then again, dealer's choice, it really allows us to plasty. And this is sort of an idea as to how many cases we have done, a standard IR versus high def. And you can imagine that when you look at the number of cases which went over 1 gray, were 80% versus 12% with the high def. And it's just better visualization results in a shorter, faster procedure, even though the pulse might be larger, but the area is restricted enough that overall the product is something which is a more refined, better compared to, you can see even just these footprints of the actual exposure. You can see the high def dose is a lot lower. This is a couple of other cases, and then we'll sort of stop. This is 64-year-old who presents with double vision, 6-nerve palsy. There is ugly aneurysm. You can see 3D imaging showing you the entire segment is dysplastic, but it's ideal for flow diversion. And we do a balloon test occlusion in these ugly cases to make sure that the patient will tolerate it. And once we know we're good, then we get dual access, one with a 5 French system for coiling, the other with a 6 French. And there you can see we're going across with the microcatheter to get into distal circulation. And then we are jailing a microcatheter, as was shown by Dr. Caputo as well in one of our cases. And once we have a microcatheter jailed, then we are going to deploy the flow diverter very slowly. I don't want to jail the A1, so it's going to be just proximal to the A1. But again, the kind of imaging visualization that one is seeing with this is quite spectacular in terms of exactly what you're opening where and how you're going to get through. And I like to do the flow diverter part first, because this then allows you to go ahead and coil. So here come the coils now, once we know that we have completely covered the aneurysm and it's well covered. And once we've done that, now you can see there's that jet that's still going in. So this requires coils. And that makes the situation much more secure and much less risky. Again, the patient's being done awake, and you just put lots and lots and lots of coils. And this is literally, there's a plasty right there because we feel that there may be a little lack of connectivity. So then there's a transform balloon which is brought up, and there you can see the plasty to make sure we get really ideal visual. And there's the final results, 18 lateral views. Very next week. So when we look at this is, I believe, another case. Radial sheath of fusiform Ica aneurysm. This is another one we'll be getting access, again, ugly fusiform aneurysm. And when we have this straightforward, trying to make sure that we can get through to the other side. Prior to flow diversion, this was really challenging. With flow diversion, it's really straightforward. The key thing is to make sure that we get through the prior stents. And this is the beauty of being able to visualize the prior stents. So once we have this placed, this is now the evolve stent, which is being played through the previously placed Elvises. And there comes the delivery system. Again, visualization is key in making sure you're inside the lumen, you're not outside. Once you have this in place, then you start delivering the device. And we'll show you exactly how the device delivers as well. It's making sure that we have distal access. And once we have deployed the whole thing, then we are very happy with it. And we make sure we approach the whole thing. So here I'm going to start showing again how the device is being deployed all the way. You can see the entire outline of the device, and there we have good wall apposition. So that sort of wanted to show the visualization ability. This is a more straightforward case. It's a basilar aneurysm, standard stent coil, nothing too fancy, with a transradial approach. And there is the stent which is ready to come out. And now we're getting ready to go into the microcatheter. We usually like to have a coil in the aneurysm before I start putting a stent. There comes my stent being deployed. Again, you can see there's a device being deployed. Even this Atlas stent, you can sort of see the lines on here, and under regular fluoro, it's much better seen than it is right now. And once we see this, once we start putting coils, we then just continue to put coils still. We're happy. And this is sort of the final result. And that is quite adequate. Another case example is a web. Again, 5mm web. These can be quite challenging in terms of how to see. So I'm going to go straight to the key part of deploying a web. There is the aneurysm right there. And so now we're going to go up with under standard magnification. And once we are there, now this is under higher def magnification. And you can start seeing the device being deployed, you know, what its interaction is. There's the bleb, that's the one you want to avoid. And once we have that much open, then you are actually, as you're pushing the device, you're unsheathing the microcatheter. There you can see the hands as to what's happening. And you can see it's starting to form its shape. And as it forms its shape, then you actually relax a little bit on the pulling and do a little bit more of the pushing to get that last little bit out. And there, it just popped out. The shoulders popped out. It looks really good. And then once you've done this, then what you want to do is do a little bit of fluoro. And there we go. You will see the fluoro. There we go. So that under high def, this is again high def, really shows very, very nicely, very good positioning for the case. Again, high def showing excellent positioning, excellent occlusion of the aneurysm. And that's exactly what you're sort of looking for. And this is the last picture here that shows you right there. this is the kind of visualization you get for a web in the skull. This is through the skull base, through the nasal bones. This is the lateral view, which is slightly less crowded in this instance, but it really allows you to see the details of the actual device, the detachment zone, the pinched area. That is quite spectacular. And really, I don't think we've seen it with anything else. Here's a pseudotumor case of venous hypertension. And again, this is standard fluoro. We know where we are. And then this is under high def, and then just look at how beautifully you can see the stentines and the segment, and we start opening it. We are going to now show how nicely it starts opening. And that really makes a huge difference in terms of deployment technique. So there it is. So there's too much pressure being applied forward. So we're pushing it. I don't think we need to do that. So we can actually see, relax the hand a little bit. And now it's being delivered much more nicely. There's no reason to compress, and the whole stent and every single tine can be very nicely seen. And once we have done that, we can do a run and show, we can do some measurements. And then we'll typically do a run and then close up. So I think at this point, this might be a Comaneci case. I have lots and lots of cases. There's a stenosis there. And so this is a stent being deployed in the vertebral ostium. There you can somewhat concerned that there may be a little overhang. So this is called a flash ostial balloon, which where we inflate the balloon, and then we use this flash ostial to really open it up. So we do that first, and then we see there's the aneurysm. Then we cath the aneurysm. Again, high def, we confirm we get access distally for making sure that we have access for an aneurysm stent. And then we start coiling because we are concerned, otherwise coil will occlude. And now the atlas being deployed just perfectly. So it's sitting right at the ostium, right there. And now we can go ahead and coil the aneurysm very securely to make sure that's well treated without any issues, and pack the coils. And this, the final result looks quite excellent.